You have this extensive experience in treating liver, gallbladder, pancreatic, neuroendocrine tumors, published, as we said, tons of research papers. So what do you consider to be the most significant advancement in these fields over these years, and how you think these advancements are impacting on patient outcomes and quality of life of our patients?
Yeah, sure. That's a great question. Well, I do think it's an exciting time in the area of solid malignancies and in particular GI malignancies. For many diseases where there was no real effective or any systemic chemotherapy, there has been significant progress. I mean, I think what I see is some of the areas that had the most advancement is immunotherapy and targeted therapy. So moving from not only describing, mutational, differences in tumors, but actually targeting those mutational differences, and combining immunotherapy with traditional systemic chemotherapy. So just a couple examples, if you look at hepatocellular carcinoma, where there was no real effective systemic chemotherapy, sorafenib offered a modest, survival benefit at best. Now I think, with IMbrave data and Tazo-Bev, moving more to new adjuvant approaches, the patients who have hepatocellular carcinoma, to even downstage them to make them resectable. And then, using adjuvant therapy in the setting of hepatocellular carcinoma for those patients at high risk. I think these are all very exciting fields. And then if you look at intrahepatic cholangiocarcinoma, disease that, we've spent a lot of time focused on in our research group, there's been significant advancements with regards to, targeting IDH1, FGFR, mutations, or also BRAF, and also combining immunotherapy with traditional systemic chemotherapy, like the TOPAZ trial with Dura plus GemCis, showing a benefit from these patients. So I think, molecularly profiling these patients, identifying their mutational abnormalities, and then targeting them, and really more of a personalized approach to these patients of these tumors have been some of the most significant advancements in the field over the last, I'd say, 3 to 5 years.
You partially already answered what was my next question, indeed, because as you are a surgeon, but still I can see you have an integrated approach in facing the disease and the patient. So you have this personalized approach. So it means that you also interact with say biotechnologies, for instance, to use the omics to better profile your patients. When you talk about adjuvant therapy, that is not just surgery, means that before and after you still follow your patient, right?
Yeah, I tell patients, these are complex problems, so they're going to require complex solutions. So, I think patients who have, liver, gallbladder, pancreatic, intrahepatic cholangiocarcinoma, I think there's good data to suggest that these folks benefit from being seen at high volume centers, and also centers that have multidisciplinary care. Because really, in order to achieve the best chance at an optimal outcome, it is going to take a multidisciplinary, multimodality approach that frequently is going to involve not only surgery, but medical oncology, now even bioinformatics and big data to understand, some of the genetic information that we're getting. Also, it's going to require, our colleagues in radiation oncology, and then even, platforms that offer, clinical trials, novel therapy. because there's so many things that are emerging very quickly that being seen at a center that can offer a potential trial, I think can benefit patients. So yeah, it's really a team approach and a multidisciplinary approach to these patients.
You made lots of research, and I can feel from what you are saying that you are still much involved in this research. So the question is, in your opinion, which of the findings, the latest findings, have truly impacted much in improving patient outcome? In the research you made in the last decades, say, what would be, in your opinion, the finding that could be translated in something that really helped?
So again, I do think it's, systemic therapy. I always use the analogy of colorectal liver metastases that, 20, 30 years ago, maybe longer now, time flies, but we were treating with like 5-FU or doublet therapy. And, whatever we did as surgeons, yeah, we moved the needle a little bit, but it wasn't until really we had much better systemic chemotherapy for colorectal metastases with, FOLFOX and FOLFIRI and combined with biologics. And that paradoxically kind of opened the indications for who we would operate on. When I was a medical student, people said, the chemotherapy is going to get so good that it's going to put surgeons out of business. But I think it's the exact opposite, that as systemic therapy gets better, we broaden our indications for surgery. And we even see that for pancreatic adenocarcinoma. It's still controversial, but there's more and more centers that are considering operating on patients with oligometastatic disease to the liver for pancreatic adenocarcinoma after they've been heavily treated with systemic chemotherapy and there's good patient selection. So I think the thing that is really moving the field forward again is molecular-based therapy, genetic-based therapy, immunotherapy, targeted therapy. That has allowed us to better control disease systemically. And then we kind of broaden our indications for who we might operate on. I do think in the future, this whole idea of like liquid biopsy and ctDNA will continue to evolve because I think that can be very helpful in perhaps identifying who's going to benefit the most from surgery. Because if you have measurable disease in the liver, let's say, but no measurable ctDNA, right, that may, push us more to operate on that patient, even if they had traditional kind of criteria based on morphologic tumor features that we wouldn't operate on them. But if their ctDNA is negative, it may suggest that doing a big operation will benefit that patient. And similarly, in the adjuvant setting, I just saw a patient in clinic today, yesterday, when we're talking about the role of adjuvant therapy. And I think in some patients, after you operate on them, if their ctDNA is negative, it may suggest that they don't need adjuvant therapy, right? That we can do a watch and wait approach. But those patients who have persistent positive ctDNA, they may benefit from adjuvant therapy. So I think again, molecularly informed therapy and also tailored therapy. So not everyone's getting adjuvant therapy. We're trying to figure out if you need adjuvant therapy based on the molecular profile of your tumor, based on liquid biopsy, ctDNA, and I think that's where things are headed.
So I know that you have also a very empathic approach with your patients, and you care much about communicating with them, and this is, of course, a critical aspect also because patients, if the patient is involved in the cure, it participate actively. So, what is, in your experience, the most critical aspect in this field of communicating and having this empathic approach with the patient, and how we can improve it to, again, improve the treatment and the What is your opinion on this?
We've been talking a lot about, personalized medicine to treat tumors. And I think, we need to move towards personalized shared decision-making. So, I think all too often we think of shared decision-making as this monolithic, one size fits all, that, this is how I do shared decision-making, right? We walk into the room. Yet what we have learned from some research that we have done and multiple other people have done it is that the most satisfaction patients get and the least likely they are to have like decisional regret or remorse is when decisions are made based on how they want the decision made. So some patients want to be very autonomous. They want to involve their family. They might want to involve their community. They may want to make the decision, over 3, 4, 5 days. They need a couple weeks to think about it. Other patients, they want it to be very much, the physician's decision. They want, they want to be informed, but they really want a lot of help and they want a lot of advice and they're leaning on you and they want to make the decision today. So just as tumors have different genetic, molecular profiles, patients and individuals have different profiles with regards to how they like to make decisions. And the more that we as physicians can meet patients where they're at and better understand how patients like to make decisions, the more, and again, the data empirically show this, that they'll be satisfied with those decisions and they'll be less likely to have anxiety, depression, and decisional regret later on about the decision that was made. So, I think it's super important, although difficult, to figure out, how patients want decisions made around these big topics. Whether they want a big operation, whether they want to receive a drug that offers a benefit perhaps of like 3 to 4 months of additional life, but it's going to have a big cost associated and some toxicity associated with it. So I think that's really, really important to figure out where patients are at. And we're doing some ongoing research here at Ohio State around that.
So we are going to the end, and say, basing on your big experience as also authors of many articles and books, textbooks, and your experience in the field, what would be your advice for young students who want to start the surgeon journey, the adventure as surgery in surgery? What
Sure. So
would you tell them?
Yeah, so I would say a couple things. One is follow your passion, right? Follow your passion and figure out what you're really passionate about. Because if you're doing what you're passionate about, it's not really work, right? I mean, I love what I do. I love writing papers and thinking about these issues. And so while some people might think that's arduous and a lot of work, I love it. So do what you love, follow your passions, and I think it will also help avoid burnout because if you're doing what truly you love and not what you expect, you're not doing what you think others expect of you, it's less likely you're going to get burnt out. So I think that's the first thing. Follow your passion. The second thing I would say is be curious. Try to always be curious and asking questions. And when you're in different clinical situations or at meetings, be asking why, I don't understand, can you explain, because I think most great clinical research questions come from the curious mind, right? We see something in the clinical setting or the OR and it doesn't make sense. And so we start asking questions, and then you can build an interesting research question around that will be clinically relevant and impact patient care. So I would say be curious. And then I think the third most important thing for especially more junior people starting off is find a mentor.
Yes,
find a
I think.
mentor.
Yeah.
Because I think, there's this old African proverb that, if you want to run fast, you run alone. But if you want to run far, you run together. And I
Yeah.
think team-based science, working with others, collaborating, leveraging different areas of expertise, and team-based research is where you can really start to be productive and do more transformational things. And if you are junior, you really need a mentor who can
Mm.
help, get you
Yeah.
started, and really have your interest in mind and promote your career and get you off the launching pad.
Yeah. I'm so glad that I fully agree with what you said. Passion, curiosity, and have good training with a good mentor. So growing up in a good environment where the others help you to grow up and learn and improve the skills. Well, it was so good to have this interview, and I think that all our readers will enjoy to listen again and again what you said. So I'm very, very happy and grateful to you for staying with us. And with this, I think I know that you are busy. You have to go for a meeting somewhere, I think. And with this, I would leave the word to Frida for the last things. And thanks very much, Tim.
Thank you.
Thank
This
you.
was great. I really appreciate the opportunity.